right. So in this particular talk, first of all, let me introduce myself. I forgot. My name is Felipe Urdaneta, and we continue with this issues of topics of airway management. And our next subject is one that basically it's surrounded by mystery, and it basically I think that the same certainty that we have about what you see in the on your screen there with the um, Bigfoot, Loch Ness Monster, the Bermuda Triangle, etc. I can describe it, I think, with more certainty than I can describe the issue, the mystery surrounding the preoperative airway evaluation. This is something that is a very intrinsic concept in terms of airway management. However, is surrounded in mystery, and I think I want to give you his ideas about where I think we should be heading, and more importantly, give you kind of a different philosophical approach as to where you should be taking your evaluation goals. As always, basically, remember you have a set of recommended suggested readings, and do take a picture of this QR code. You will get a PDF with the references. You can download whichever you want all and start building your library and follow along as you go and see this lecture happening. So the first question is, I think that what if what we have been doing for the past 40 years with preoperative airway evaluation is wrong? What if it's basically a situation of the emperor has no clothes? And as you know, the emperor has no clothes is the situation where the majority of observers share a collective ignorance of an obvious fact despite individually recognizing its absurdity. And I think that's exactly what's happening with our current method of airway evaluation. I think basically we've kind of taken the teeth out of it and we made it kind of a morning ritual type of thing. It's kind of not giving it the importance that it requires. Yeah, sure, we fill up a form and it's filled and all that, but are we really taking that information we're doing with the evaluation and putting it to use? That's the question that I want to actually bring up to you. And I think that that question I've been actually having for the past 20 years since I've been doing this. Well, the first thing is we always do it, and you see a picture there of a man. That's Rao Malampati. So every time you do a Malampati test, and you will be doing thousands, maybe 100 per week or so, is you owe kind of a, oh, this man basically deserves credit for what he did. And what he did was basically come up with a criteria that if the tonsillar pillars were hidden, then you were going to have a difficulty having direct laryngoscopy. But here's the truth, and the movie played faster than I could actually speak. I think it will be important if it had basically a great degree of sensitivity. However, in the larger studies that is over 177,000 patients, the sensitivity of the Malampati score is only about 37, uh, which is basically kind of puts you kind sensitivity. In fact, all of our tests that we do criteria are plagued by low sensitivity. So what does that mean when you have something that is 40 to 53%, or in the case of the Malampati, 37%, is that you have a better chance of being right if you toss a coin. And I want you to think about that. Another thing that is very important is keep in mind that all these tests were developed in an era where there was only three things that we could do for the airway. It was direct laryngoscopy with a straight or curved blade, flexible scope intubation, or mass ventilation. That's when all these tests were developed. Nowadays, with the onset of new devices, for example, the supraglottic devices, and we cannot discard the use of video laryngoscopy, this test or the sensitivity of this test um, even comes into more question. That doesn't mean they're not important. That means that you have to actually put them into your equation, but not give them the same importance as we did perhaps 20 years ago. Now, one thing is that they're all plagued by inter-observer variability. What I'm seeing might be different than what you're seeing. Is it a 6 or is it a 9, like the cartoon says? Well, that's actually important because things that you can measure are more important or more kind of interchangeable than things that you can actually interpret. So, for example, looking at the mouth opening, you can measure that. You can get a ruler for that matter, or a test of finger breadths. That's measurable. However, the finger breadths I'm not particularly fond of because it all depends on the size of your fingers. The chin distance, the theromental distance, the atlanto-occipital extension, those are being measured. But you can see, for example, in this graph that the Mallampati score is all plagued by different criteria. And one person might say it's a 2, one person might say it's a 3, etc., etc. So there's a lot of interchange variability. One of the things that I think it's important to consider is as well the context in which you're evaluating your patient. It's completely different to do, for example, an evaluation where you have time when it's in the outpatient clinic or something like that, as versus a patient is, for example, trapped inside a vehicle, as you can see from this slide, in a helicopter. Well, those are two different completely things. The other thing is some people have actually looked enough and said, well, are we making it too simplistic by just basically asking the patient to move the neck up and down, open the mouth, and perhaps actually look at the Mallampati score? So what this group did, which was an amazing study, is they said, well, maybe it's not comprehensive enough. So they separated the patients into two groups. In one group, they did a very thorough examination. As you can see from that test, that form had to be filled on every patient. And the other group had to do basically a 2-second minimal exam, mouth opening, theromental distance, neck movement, something like to that effect, something that we can do at bedside quickly. And guess what? There was no comparison between them. In other words, if you do a thorough exam or if you do a quick exam, you're not going to actually have better results if you do a more thorough exam. Because I think one of the problems that we have with airway management, specifically with evaluation of the airway management, is that we have done it wrong for many years. See, the whole thing, and you can see from this slide, is that we've tried to predict whether the airway is difficult or not. And let me send some cold water to you, but you're not in the business of predicting. That's not what you're here for. You're in the business of actually being prepared in case things are difficult. So take away that term prediction, because that's not what you're trying to accomplish. Because whether it's difficult or is easy, you need to handle it the same way. You need to be prepared for both. And so one of the things, for example, this is the famous Danish airway database study in which they looked at over 188,000 patients, which is huge in terms of airway numbers. And they looked at that and they were able to predict difficult intubation in 25% of the patient and difficult mask in somewhere to 22% of the patient. So in reality, we're not there to predict. That's not our goal. That should not be our goal. We should be there to be prepared in case things go and turn difficult. So that's one of the take-home messages that I want you to have is, yes, you can do it. You can do it as a ritual. You can develop your own kind of sequence that you do things. But the important thing is that you're not trying to predict. You're trying to be prepared in case things go wrong. And I think that one important concept is like the weather. Prediction and preparation are two different things. A forecast, for example, is something more important because it covers a range of possible outcomes. And that's what you need to develop, not predicting, but like a forecast. Well, what's the degree of difficulty that I'm going to have? If I, for example, look at a 280-pound patient with obstructive sleep apnea and huge tongue, well, more than likelihood, I'm going to find difficulty not just ventilating, face mask, but also intubating. So that's kind of the idea that I want you to give. So one of the things that I propose to you when you're doing your evaluation is that you do a stepwise approach. What is the stepwise approach? Well, the first thing is you do your routine evaluation. For example, ask for the presence of common things. Is the patient obese? Does the patient have obstructive sleep apnea? Does the patient have any anatomical distortion or cannot open the mouth because of TMJ problems, etc., cervical spine issues, poor tolerance to hypoxia. That's a common one in which we see a patient that is basically that's going to desaturate quickly. Well, those are things that we should be actually assessing ahead of time. The presence of NOD or GERD. And what I mean by GERD is not the typical dyspepsia that you might get with a heavy meal. I'm talking about people that have frank reflux. Those are the ones that are important. And things that you also look for is red flags when you're evaluating your patient. For example, has the patient had previous surgery and they encounter difficulty? Patients usually do not exactly recollect or remember that. They might tell you about different clues. Like, for example, were you told that you had difficulty? Did you have an unusual amount of sore throat? Were you admitted to the ICU afterwards, or did you require a tracheostomy? Things like that. Sounds dumb, but it isn't. Um, were you told to wear a bracelet saying that you were a difficult intubation? You might consider that's dumb, but it's actually a very important question that you should be asking. Another important thing is that you should be doing the laryngeal handshake in every patient. What's the laryngeal handshake? Well, it's basically what we call is we palpate for the location of the cricothyroid membrane, and we'll talk more about it when we're together. But the whole point is that in the conclusion of the team that I told you of that study where they compare the comprehensive versus the quick exam, the conclusion was that perhaps the most important thing that you can actually get from your preoperative evaluation of the airway is if you perform location of the cricothyroid membrane, and not just clinically, you can also then escalate it and you can do it via ultrasound. Another important thing is that you should always review all records, and that's not just about intubation, but also in terms of imaging techniques. Very important, for example, when we're doing ENT, if the patient has had an MRI, for example, or when was the last time the patient had an MRI, or is there any CT scan of the airway, where is the deviation of the trachea, or something to that effect. Those things are very important. I want you to start thinking not just that intubation is important, you also should start thinking, is it the laryngoscopy that's more than likely going to be compromised? Is it going to be face mask ventilation? Is it going to be supraglottic? Is it going to be all three? Or is it going to be that the difficulty might lie at extubation? For example, the patient might come for TMJ surgery and the patient is going to basically leave the OR with a wire shut mouth because of wires. Well, that's a difficult extubation, and that's what you start thinking, okay, mechanistically this is what's going to happen, so that's what is important. A dumb case study, but it's actually very relevant, is I always bring this up, is Santa Claus. Well, think about it, right? Santa Claus, he's obese. um, More than likely he has a full stomach, if you see him in Christmas time, of course, and he also has facial hair. He's a voice professional. He more than likely has GERD and possibly has obstructive sleep apnea. Do you think that Santa Claus will be a difficult intubation? I believe he would be. He would not also be difficult intubation, he will also be a difficult face mask ventilation as well. And because of the issue that he's a full stomach, he might not be the supraglottic, might not be the first choice. So I believe that if you start thinking about that way, and you start saying, hey, listen, think I'm going to face difficulty in all aspects of airway care, then you might change your plans, and that's actually important. So that's what we need to talk about, how we do it, how am I proposing to you that you should be doing it? You should be looking at the future. And number one, as I already told you, the laryngeal handshake is very important, and you can do it clinically, but you can also do it via ultrasound. And there's a lot of groups that are marking the cricothyroid membrane before they even actually begin instrumentation of the airway. Why? Because if everything else fails, the only last ditch effort is going to be performing a cricothyroidotomy. So if you know where the cricothyroidotomy, the cricothyroid membrane is, then more than likely you'll be able to do it correctly. Other groups, for example, this is from a friend of mine. He performs flexible scope before the patient in the holding area via the nose. So then he looks at the potential difficulty that he might encounter. What he found in this particular study, which you have in your reading material, is the fact that they were able to avoid awake intubation in people that do not need it. And more importantly, they were able to perform awake intubation in people that they thought erroneously that clinically they were not going to need it. So by looking at the scope immediately beforehand, then they were able to determine that. And why is beforehand important and not 3 months in advance when their patients get seen in the clinic? Because things might fluctuate and things might change. There's another things that happen there, in my opinion, with all the respect, is there's pseudoscience. There's such a thing as there's working on artificial intelligence and facial recognition, computer analysis. So there's people working on that and trying to predict the ease or difficulty. And it seems very promising, but I don't see yet the practicality of it or the potential for actually being something that you can be done quickly or something to that effect. Another thing, some groups are working on virtual laryngoscopy and 3D airway. Very, very important as well. But again, not very practical, or that something you can do on the fly or in the middle of the night or on a weekend or something like that. So those are things that are reserved for a specific patient population. So bottom line is what I've told you is that there's a lot of mystery surrounding the issue of preoperative evaluation and things that we can do. And I hope I'm giving you some clues today of things that you could be doing better. And my point is that when you're going to do an evaluation, then basically what the information that you obtain from that evaluation is going to lead you to change something in your practice, whether that is you position the patient differently, you get a different device, you escalate the device, you get more people in the room to help you, etc., etc. That's exactly the whole goal of the preoperative airway evaluation. So look forward for seeing you in the OR, and hopefully everything is going well with this introduction lecture series. Thank you.